presented in ESCRS, they also significantly found that vertical coma induced is more even in the most advanced laser system for higher refractive errors. So even a good tracker, if the patient is moving a lot, will have a slight latency period where the tracker moves. So that was the idea.
My second question is, you have made a flap and you're putting an instrument on top of that. Will it not hurt the flap when you're putting it? And if the patient moves, it may just break the edges.
So it is designed in such a way that it is extremely blunt and you don't have to apply too much pressure while putting it. The teeth are blunt and the undersurface of the flap is very blunt. So we have done it on now more than 300-400 eyes, and it has not caused any post-operative complications or intraop complications to the flap.
Pressure, but the patient may suddenly move the eye and
the patient doesn't move, cannot move the eye because the teeth are holding the eye. The teeth are holding the globe at the sclera. So once you apply the instrument, there's no movement from the patient at all.
You're saying you have to be gentle, but very nice. Good, thank you.
Thank you.
You should put the slide with the reverse side of the instrument showing the teeth and the plane surface which is opposing the flap.
Yeah,
so
below the flap is plane and the rest of it has
that
teeth.
will give a better impact in your presentation.
Okay, below the flap is...
Below the flap there is no teeth and the rest of the globe has
That makes sense. Okay.
So I would request Dr. Shravya Karna. Is she here? Yeah. And she will be discussing about the efficacy of moist chamber in prevention of exposure keratitis in patients of ICU.
Good morning, everyone. So I'll be presenting a study which we have done in our ICU setup. This is to assess the efficacy of moisture chamber goggles in the prevention of exposure keratopathy in patients in intensive care unit. No financial disclosure and ethical clearance is obtained. And coming to the introduction, exposure keratopathy is damage to the cornea that occurs due to the prolonged exposure of the ocular surface to the outside environment. And exposure keratopathy can also lead to the ulceration, microbial keratitis, and permanent vision loss from the scarring. And several factors help in maintaining this teofilm, which includes intact blink reflex, normal blink rate, complete eyelid closure during sleep and blinking. And in critically ill patients, these protective mechanisms are really challenged. So these are the ocular conditions which can be seen in ICU, the lag of ophthalmos and exposure keratitis. And when the timely treatment is not done, it may lead to the adverse conditions like corneal ulcer and may also lead to the blindness. And the purpose of this study is to compare the efficacy between the two groups, comparing the efficacy of using a combination of ocular lubricants and lid taping with the use of moisture chamber goggles to prevent exposure keratopathy. So coming to the literature review, these are the articles which said the moisture chamber goggles versus lubrication for corneal protection in critically ill patients, where moisture chamber goggles have showed statistically significant results. Coming to the methodology, the study control trial and done in MS Ramaiah Medical College and Hospital from period November 2024, and sample size is 62, where 31 cases were taken and 31 controls. And materials used are moisture chamber goggles, lubricating eye drops, micropore tape, and the AC vent and the position of the bed was also considered to monitor the atmospheric conditions, where the atmospheric conditions across all the beds were titrated to be similar. And inclusion criteria is comatose patients with reduced relaxants and mechanically ventilated patients with low GCS score, and patients in ICU for at least 24 hours. And treatment with topical agents other than the lubricants and patient inflammation to the eye. Coming to the procedure, 62 patients where two groups were done, receiving ocular lubricants and the lid taping considered as open chamber, and the group receiving the moisture chamber goggles acted as the closed chamber. And detailed eye examination was done, including lag of ophthalmos, Bell's phenomenon, blink rate, pupillary reaction, and corneal changes were noted using 1% fluorescein under cobalt blue filter in direct ophthalmoscope. And corneal staining was done, and cases and controls were followed up till they're out of the intensive care unit. And two groups are compared with respect to staining, and data analysis is done using SPSS data tool, and the results are documented. So these are the pictures where the moisture chamber goggles were put onto the patients, and this is the corneal staining pictures which are taken. And coming to the results, to the agent sex matching was done, where 20.5% were females and 59.5% were males. And Age, 2% were below 20 years of age group, and 9% were between 20 to 45 years of age group, and 89% were 50 to 90 years of age group. And coming to the results, conjunctival injection, we have compared on day 1, day 3, and final day. And we've showed, the p-value showed for day 1 it is 1, day 3 0.21, and final day 0.24, which is not significant. Same as well as in the corneal staining, where the day 1, day 3, and final day corneal staining was compared between the open chamber group and the closed chamber group, where the p-value showed, say the same, day 3 is 0.1 and final day it is 0.2, which is not significant with compared to both the groups. And in patients who were shifted to step-down ICU after they've recovered, there was an improvement in the blink rate. And so according to the review of literature, moisture chamber goggles were attained maximum corneal protection. And the moisture chamber goggles usage, giving instructions to the staff in the ICU was very easy and less tedious job. And it helps in enhanced moisture tear retention, humidity control, protection from irritants, and ease of use, and improved healing. So according to this study, where the nurses felt that the use of lid taping was due to like lack of knowledge, lack of time, too much work, too much documentation, and not an important job. This was the factors which prevented the adequate eye care, considering the nurse's point of view. So coming to, considering all these conditions, moisture chamber goggles are equally effective in preventing the exposure keratopathy, and especially in the intensive care setting where life is deemed more important than the sight, and ease of use are equally benefits with less efforts, showed moisture chambers are equally effective compared to lid taping.
How was the blink rate improved? You commented that with moisture chamber goggles, the blink rate improved.
Ma'am, after we've put the goggles, I mean, like the lag of thalmus, I mean, like when the exposure, the dry eye symptoms were weaning, and like the dry eye symptoms were weaning, and the patient got better. The blink rate was also, I mean, like when the shifted, when the day of this discharge or like that, the blink rate was like increased previously. Huh?
How can you comment? How can the blink? Do you have any reason to improve the blink rate?
Because we have put the goggles, maybe the corneal protection was taken care, and the tear film was I mean, like there is increase in the tear film protection. So
So who measured blink rate in ICU with a goggle on? This is not acceptable. Who measures? Sisters are there in the ICU. Who is going to measure the blink rate over there?
no, we have gone and we have assessed the
How
sisters,
do you assess the blink
with
rate?
patients.
How do you assess the blink rate?
We'll ask the patient to blink. I mean, like,
You ask a comatose patient to blink?
no, not all the patients are comatose, ma'am.
Yeah, the patients in ICU, do you ask them to blink? Most of the time they are not in their senses, they are irritable, and they don't blink rate. That's what I'm asking.
Yes, ma'am, I agree. Most of them are disoriented. Most of them are
Yeah,
like
so how do you assess?
irritable. But the patients who are following the orders, I mean, like we could document on those patients.
That's what I'm asking. How did you document it?
Those patients who are already in a state of coma, we cannot
We can notice.
those who are blinking their eyes, I don't think so that they need such glasses.
Correct.
Those who are blinking, they must be good enough.
But the blinking rate is very less, so
So what is your
Like
comment on
those
this?
patients
Like
who are already
I agree
blinking
with you.
their eyes
I agree
will
with
not be
you.
having
I agree with you.
That's the main plan is also.
Okay, Dr. Cornea, nice presentation. But as a judge, I have to tell you that you have to remove one slide in it, in which you have already said that you have received the best paper award for this at some place.
yeah, because
That is making things biased.
no, sir.
Judges should not know what happened earlier. So everything is all right. At least that certificate should have been removed. So you're already telling the judges that I have received the best paper.
No,
for this.
it's not done by us, sir. I mean, like at our center it was done, so that's how we've got the.
That slide is there which is saying that this paper has received an award.
Yes, sir.
So that's what I'm saying. It makes things biased. It's not fair to the other participants. Number one. Number two, how are you creating this moisture within the goggles?
So because of the closed chamber, closed intact the goggles.
So it was
Which
patient's own sweat which was evaporating and causing the moisture, or what was it?
it is the, so these are the goggles which we've used, and
Where
because
was the moisture coming from?
it's because of the closed environment. I mean, like it is not evaporating. I mean, like the it is because it is closed. the air is not going out, so the evaporation will be there.
Are we making the eyes more susceptible to any kind of infection by closing it so that no air or nothing is going in? You're not using any drops, you're not putting any antibiotics, you're not doing anything?
Correct, sir. For that reason, we've been followed up continuously till the patients are there. I mean, like daily we've followed up and daily we've gone there and we've seen the patients.
And so there's one group with tear lubricants, there's one group with goggles. It may be a good idea to see with a third group with lubricants and the goggles if there's any improvement. But I totally agree with what Dr. Kavita is saying, that it's very difficult to assess the blink rate but thank you very much. You have to.
And one more thing, apart from this, you are putting one more instrument on the patient who is already on instruments, and on instruments. Okay.
The question was how the moisture is coming inside the glasses. How the moisture is coming here.
That'll take a very long time for the sweat to evaporate. What do? You keep sitting there next to the patient, seeing when the moisture will come and how much moisture is there. How do you quantify the moisture? Huh? Thank you very much.
I have one more comment, like the moisture do come from the breathing process of the patient. So patient have a lot of pipes inside the mouth, so the moisture can come through the breathing of the patient.
If it's coming through the breathing, then it will make the eyes more susceptible to infections.
And we are not putting any eye drops with the goggles on. No. Okay, thank you.
Thank you.
So next we have Dr. Nupur Dubey. She will be presenting DSEC in case of failed PKs.
So good morning all. My topic of presentation is DSEC in failed graft patients and outcomes. Despite the increasing success of penetrating keratoplasty, graft failure remains a very important problem. There are two options for visual rehabilitation. Either we can plan a repeat penetrating keratoplasty, which has a long-term survival rate of 21% to 70% in such cases, or we can go ahead with an endothelial keratoplasty. These are the advantages and disadvantages of doing a DSEC in a failed graft. Most significant being advantage being less chances of intra-op complication, especially expulsive choroidal hemorrhage. So we decided to conduct a retrospective study to report the visual outcome and graft survival of manual DSEC in cases of failed PK grafts in a tertiary care center. We included all cases of DSEC done in failed PK grafts with a minimum follow-up period of 4 months. All the cases were operated by a single surgeon and DSEC graft preparation was done manually. This was the data which was collected for our study. Coming on to the results, so we included a total number of 8 patients. Mean age was 48.12 with age ranging from 28 to 64. 75% of our patients were male. Most common indication for initial PK was non-healing corneal ulcer in 37.5% of our cases, followed by perforated corneal ulcer and a corneal scar. Initial PK diameter was 8 mm in 37.5% of the cases. All our patients had undergone only one previous PK. If we talk about the rejection episode, then 3 patients were not aware of any rejection episode before PK failure, as they were referred to us from outside. 3 patients had one rejection episode and 2 patients had no history of any rejection episode before PK failure. If we talk about the DSEC donor diameter, then it was 7.5 mm in 62.5% of the cases. Decimate stripping was done in 62.5% of our cases. If we talk about the lens status, then 50% of the patients had cataract, 2 patients were pseudophakic, 1 patient who was very young had a clear crystalline lens, and 1 patient had an anteriorly dislocated PCIOL. In the patient with a clear crystalline lens, we performed a phakic DSEC, and in the patient with an anteriorly dislocated PCIOL, we performed a DSEC with IOL explantation with pars plana vitrectomy along with a scleral fixation of the IOL. So if we compare the pre-op visual acuity and post-op visual acuity at 4 months, then we can see that in most of the patients, the visual acuity did improve. In fact, we were able to achieve more than Snellen best corrected visual acuity of more than or equals to 6/18 in 50% of the patient. In 2 patients, the visual acuity did not improve much. One patient was later on found to have a macular scar, and one patient along the course of the treatment developed a fungal keratitis and ended up with a poor visual outcome. So this is the pre-op and the post-op image of the patient who underwent a DSEC with an IOL exchange. This patient had, in this patient on POD5, an inferior graft detachment was noted, which was successfully managed with the rebubbling procedure. This is the pre-op and the post-op image of the patient who underwent a phakic DSEC with us. And this is the patient who underwent a non-decimate stripping DSEC, which shows that even if we choose to not strip DM, in some cases, the results are equally good. This is a patient who underwent, who in spite of having a clear graft ended up with a poor visual outcome due to a macular scar which we were unaware of. This is the patient who after an initial period of graft clearing developed a fungal keratitis and had a BCVA of county finger at 1 meter at the end of 4 months. So to summarize, in our study, indication for initial PK was either non-healing corneal ulcer or perforated corneal ulcer in maximum number of cases, which is in contrast to most of the published literature from the Western world, where most of the cases are done in post-optical PK cases. DSEC donor diameter was smaller than the PK graft diameter in all our cases, which is again in contrast to most of the published literature from Western world, but similar to the studies done by Strico et al. And Chaurasia et al. In our study, DM stripping was done in most of the cases, again for the same reason that most TKP grafts were higher. In our study, 5% of the cases, which is similar to the published literature. The incidence of graft failure varies from 9% to 16.6% in similar studies, but none of our patients developed primary graft failure in our study. Now this thing can be attributed to a smaller sample size. So to conclude, DSEC is a viable option for visual rehabilitation of a failed visual acuity may be suboptimal, especially in the cases with the failed TKP grafts. The other benefits may still outweigh the risk associated with the repeat PK. We need to be really vigilant about the chronic steroid use related side effects such as fungal keratitis. Small sample size and retrospective nature of the study are the major limitations. Thank you.
So DSEC in failed PK
Yes, sir.
has been an established procedure
Yes,
before
sir.
also.
Yes, sir.
What was different you were trying to say over here?
So it was just done in our own cases. That's why I chose to. So DSEC donor diameter was always smaller. We have kept it smaller. Initially when DSEC was being established in failed PK, then they were saying that it has to be either bigger or the similar size, because it can conform well to the, even if the graft host junction is very irregular. But over the time it has been realized that if DSEC donor graft diameter is smaller, then it is better. The rate of graft detachment is lesser in those cases. Thank you, sir.
We have 8 more presentations to go and only 45 minutes are left. So please stick to time. And then next speaker is Dr. Vijay Lakshmi A. Senthil Kumaria. Please.
Good morning. I am Dr. A. Vijay Lakshmi. I will be presenting a paper on visual and surgical outcomes of MMC augmented NPDS phaco in patients with advanced glaucoma. The goal of any glaucoma surgery is mainly to preserve the existing vision. In advanced glaucoma, one will be reluctant to perform any invasive glaucoma surgery for the fear of macular snuff-out or wipeout phenomenon, which is reported to occur in 0 to 13.6% of these patients. Our main aim was to report the visual and surgical outcomes of MMC augmented NPDS phaco in patients with advanced glaucoma. Ours was a retrospective study. We included 349 eyes of 324 patients. We basically included severe glaucoma with significant cataract with open angles. We also included a subset of PACG patients with superior open angles. We excluded eyes who underwent standalone NPDS, mild to moderate glaucoma, and patients with unreliable visual field. All patients underwent a standard pre-op glaucoma evaluation. Also, they received a standard post-operative care. Post-operative maneuvers like laser gonial puncture and blood needling, they were not considered as failures. They were considered as blood augmentation procedures. Post-operative visits included 8 visits until 2 years. We collected all important clinical parameters of the patients, including the visual fields, intra and post-op complications. If you look into the demographic characteristics, majority were males. About 15% of the patients had the end stage of glaucoma, the common diagnosis being POAG. About 15% of the patients had a diagnosis of PACG with superior open angle. Now looking at the primary outcome measures, which was based on visual acuity and HFA mean deviation, we could clearly see there is an improvement in mean logMAR BCVA from the baseline value at all post-op visits until 2 years. Likewise, HFA also mean deviation there is a stabilization of HFA mean deviation at all post-op visits until 1 year. Now, if you look at the secondary outcome measures, which was based on intraocular pressure reduction and AGM number reduction, IOP curve is showing a decreasing trend from the baseline value at all post-op visits until 2 years, and the final value being statistically significant from the baseline value. Similarly, the AGM number also, it is showing a decreasing trend, and the final value being statistically significant from the baseline value. If we look at the surgical success based on primary outcome, that is visual acuity and mean deviation, we are able to achieve 94% success in our study participants. Fortunately, we did not encounter any wipeout phenomenon. However, we do encounter few complications which are only minimal, like refractive raised intraocular pressure. One patient had choroidal effusion, and few patients required additional glaucoma surgical intervention for IOP control. Our results on NPDS phaco reveal 94% success with stable visual field, improvement in visual acuity, significant drop in AGM and IOP without any wipeout phenomenon. Our study results corroborated strongly with the results by Mercier et al., who reported 89% success. However, the follow-up period was longer in their study. It was for a period of 63.5 plus or minus 35.3 months. And then regarding the efficacy of NPDS in PECG patients, which was not well explored or not reported earlier, we have included this subset of PECG eyes also, and we are able to achieve a brilliant success of 86% without any major complications. We would like to attribute this better success rates to various crucial factors like intraop use of MMC and deep scleral dissection, meticulous peeling of inner wall of Schlemm's canal. These two steps are very, very crucial in achieving an adequate thickness of trabecular decimens window, and use of space maintenance to avoid the flap fibrosis. All our study participants, we use dispersive viscoelastics as a space maintainer. NPDS being a non-penetrating surgery, it minimizes complications related to any invasive glaucoma surgery. It could be alternative to mix in eyes with advanced glaucoma. The major strength of a study includes large sample size with a long follow-up period, and also efficacy of MMC in patient undergoing NPDS we have explored well. We have also included a subset of PECG eyes also. Finally, to conclude, MMC augmented NPDS phaco is a safe and viable option in eyes with advanced glaucoma, maintaining stable post-op visual acuity and visual fields. Thank you.
So in some slides you are saying advanced glaucoma, in some slides you are saying end-stage glaucoma.
Yes, sir. So the advanced glaucoma, this is according to the Bhaskar-Palmer grading scale we calculated, sir. Advanced glaucoma refers to the patients having visual field defects either in the both hemispheres or within the central 5 degrees in one quadrant, and end-stage glaucoma, it represents patient having less than 0 decibel at least in one point within the central 5 degrees. It refers to advanced glaucoma. Most often this is seen in patients with more than 0.9 CDR.
Yeah, so I understand what is advanced glaucoma, but you are also saying end-stage glaucoma.
End-stage glaucoma is patients, in one slide I have shown the patient, we included both CDR less than 0.9 and 0.95 to near GOA. So here we included almost 15% of the patients had the end stage of glaucoma, but the surgeon will be reluctant to perform any invasive glaucoma surgeries for the fear of choroidal complications and wipeout phenomenon.
So did you have any, did you quantify the mitomycin C that you were going to use, or did you have any thinning?
Usually we
use of mitomycin C, you know the complications.
Yes, sir. The long-term usage of MMC, it can lead to scleral thinning, scleral-related complications. But in our study participants, we used 0.02 milligram per ml. It's a standard dose we use for trabeculectomy patients. We usually avoid in high myopia and patients with scleral thinning.
Correct.
Yes, sir. Thank you, sir.
So the next presenter we have Dr. Ragini Pundir. She will be discussing about dry eye in children in tertiary care center. And next in line we have Dr. Purva Bhatt.
Good morning, everyone. I'll be presenting on the topic, a study of dry eye in children in a tertiary care center. Dry eye is a multifactorial disease having a number of different interacting causes or influences. It is depicted by a loss of homeostasis of the tear film in association with ocular symptoms. Worldwide, it is emerging as an important cause of ocular morbidity, especially amongst the young population. Increased on-screen time and near-view work results in reduced blink rates and incomplete eyelid closure, inducing and exacerbating dry eye disease symptoms. Known risk factors for dry eye disease account for several disorders, including the ocular allergy and autoimmune diseases. The aim involves to study the prevalence of dry eye disease among the young population, and the proposed study was conducted over a period of 12 months in the Department of Ophthalmology, Himalayan Institute of Medical Sciences, Dehradun. It's an observational cross-sectional study with a sample size of 90. Study tools involve Whatman's filter paper, eye drop proparacaine, 0.5%, ocular surface disease index questionnaire, and sterile sodium fluorescence strips, along with slit lamp evaluation. The inclusion criteria: all patients between 7 to 17 years of age visiting the outpatient department of ophthalmology at Himalayan Institute of Medical Sciences, and patients with refractive errors. Exclusion criteria includes patients whose guardians do not give any consent, patients with a past history of any surgery or ocular disease, patients with active ocular surface disease, patients using contact lenses, and patients with history of systemic illness. The results include, firstly, gender distribution. In the age group of 7 to 12 years, we had 25 males and 15 females. In the age group 13 to 17 years, with a total sample size of 50, we had 26 males and 24 females. The frequency of Schirmer's test was as follows. In the 7 to 12 years age group, we had 80 eyes, out of which 2 eyes were in the category of 6 to 10 mm, and we had 0 in 11 to 15. 3 in 16 to 20 category, 21 to 25, we had 7 eyes, 26 to 30, we had 36 eyes, and 31 to 35, we had 32 eyes. In the age group of 13 to 17 years, we had 2, 1, 5 in the 16 to 20, and 9 in the 21 to 25, with an increasing number of eyes in 26 to 30 mm group. Next, we have the tear film breakup time. In this, we had 80 eyes in the 7 to 12 years category, and we had less than 10, we had 4 eyes, and in the category of 15 to 20, we had 14 eyes. 13 to 17 years age group, we had 81, which was 81 eyes that were included in the category of 10 to 14 seconds. Next, coming on to the frequency of the tear film height. In the age group of 7 to 12 years, we had 4 who had a value between 0.1 to 0.2 mm, and 76 with a value of 0.3 to 0.4 mm. And in the age group of 13 to 17 years, we had 2 with a value between 0.1 to 0.2 millimeters, and 98 with a value between 0.3 to 0.4 millimeters. Coming on to the CFS score that we calculated, 80 out of the 80 eyes, they were grade 0, 73 eyes, and grade 1, 5 eyes. Whereas in the 13 to 17 age group, we had none of the patients reported to be grade 2. The Worst scoring was as follows. We had 19 with a normal, 18 mild, 3 moderate, and no severe disease that was found. In 13 to 17 years, we had 30 normal, 17 mild, moderate, 3, and no severe dry disease was again reported. The ocular symptoms were as follows. The eyes that were sensitive to light, eyes that felt gritty, painful or sore eyes, blurred vision, and poor vision. Coming on to the visual functions that were assessed, one was difficulty while reading, driving at night, working with computers or mobile phones, and watching television. The environmental factors included windy conditions in places with low humidity, areas that are air conditioned. Now, the dry and refractive errors, we had 78 myopes, out of which the dry was present in 35 with a total percentage of 44.87%, and in hypermetropes with a sample size of 12, we had presence of dry eye in 41.66%. Discussion is as follows. Pragya Rao Donathan conducted a cross-sectional study in which children and adolescents were considered as subjects, and visual morbidity was found was limited to those suffering with SJS. Rupal Bhatt, during the year 2016 to 18, calculated the prevalence of dry eye disease to be 6% in the 7 to 12 years age group, while Namrata Srivastav conducted an observational study to assess dry eye disease, and the disease entities were found to be associated with vernal keratoconjunctivitis and overuse of smartphones. Xingrong Zhou et al. Conducted a systematic review which revealed the overall presence of dry eye disease symptoms in the myopic population to be 41.5%, and there was significant association between the two. Thank you.
Thank you.
How did you measure the meniscus height, tear meniscus height?
On the tear meniscus height, we made a slit, and we had to orient the slit horizontally, and that is how we measured it. Like, we made a 1 mm slit, and after that we can increase it because
So the height you measured was 0.1.
no, there was
It's
no.
mentioned in your slide.
That was the category, but the height that was which I found in my subjects was either 0.2 and more than that.
I'm not saying that. How did you measure 0.1? You have mentioned in your slide.
Ma'am, there were no subjects.
Can you show me the slide once again?
Yes, ma'am.
The tear meniscus height.
इनका slide on कर दीजिए.
Yeah, here.
Yes, ma'am.
Height in millimeters or 0 to 0.1, 0.1 to 0.2, 0.3, 0.4?
Yes.
How did you measure that?
Ma'am, this was basically the range, but most the subjects that I measured, there the value of the tear film height was 0.2 or more than that. Was more than 0.2.
No, I'm just asking a technical question. How did you measure it?
Ma'am, that
How
is
did
we
you
made a
measure
slit
0.1? How did you measure 0.2? How did you measure 0.3?
0.3.
You have mentioned it here.
Uh,
in like this. It's 0.1 millimeter, 0.2,
Yes,
0.2,
ma'am.
0.4.
Ma'am, we made a slit, and through the slit, we basically oriented horizontally,
Yeah.
and that is how we measure. And there are, it's the readings, the caliber is available, so 0.3, I was able to measure on the slit lamp.
Okay. Nice presentation. Slowly and surely it is getting established that even kids have dry eyes. But so many tests you have done, 7-year-old kid, reflex steering, whether the kid is cooperative or not. How do you actually say that all your values are actually true? Am I correct?
Yes. Sir, we took this particular age group from 7 to 17 years on purpose because usually kids below 7 years are all the more uncooperative. But yes, sir. But since because there is increased use of smartphones even in children who are as young as 5, so it was imperative that we included the younger children as well in the age group of 7 to 12 because the other age group is 13 to 17. So they are any which ways cooperative. But the younger age group of 7 to 12, they are relatively uncooperative. But it was important to include them as a part of my study because of the increased use of smartphones in that age group as well. So
One of your slides says driving at night.
for the, yes, it does. So,
Kids
sir,
driving.
in the OSDI score that I calculated, I have excluded that question in the patients who do not drive. Like in the age group of 13 to 17 years, there were a few children who did drive. So that question was pertinent for those candidates. So 13 to 7,
Okay,
yeah.
thank you very much.
So the next presenter is Dr. Purva Bhatt. She will be discussing about the evaluation, spectrum of dry eye disease, and effect of central corneal thickness in post-menopausal females. Do we have Dr. Purva Bhatt? Okay, okay. So next we have Dr. Shrestha Sharda. She is here.
Good morning, everyone. So I'll be presenting on the impact of COVID-19 pandemic lockdown on ophthalmic screening of preterm neonates at Surgery Care Hospital of Uttarakhand. Well, the background of the study was the preterm birth and visual health. It is associated with visual impairment, oculomotor abnormalities, and refractive errors. The cause is due to abrupt visual system to unfamiliar environments. Ophthalmic references ensure early detection and timely intervention for ocular morbidities. So the impact of COVID-19 lockdown, it was a nationwide lockdown from 22nd March to 31st May 2020. So this affected the healthcare services and ophthalmic referrals, both elective and emergency cases. The aim of the study was to assess the impact of COVID-19 lockdown on ophthalmic referrals for preterm neonates born at the institute. The key objectives were to analyze the referral trends before, during, and after lockdown, and to evaluate the changes in preterm births and deliveries, to investigate potential benefits of external environment on gestational age. The methodology used was study design was a cross-sectional analytical hospital-based study. The study period was from January 2020 to July 2020. The inclusion criteria was preterm neonates born in the hospital. They were screened for who was screened for ophthalmic issues.
Can you close the door, please?
They were screened for ophthalmic issues. According to WHO guidelines, the preterm were from the age group of less than 37 weeks gestation. The preterm categories were extremely preterm was less than 28 weeks, very preterm 28 to 32 weeks, and moderate to late preterm 32 to 37 weeks. The exclusion criteria included was the infants more than 1 month of age or who were born elsewhere. Unbooked emergency births, like who were delivered at the hospital due to lockdown, were also analyzed for comparison. Screening tools and focus used were torchlight, direct and indirect ophthalmoscope, and they were screened for congenital abnormalities, red eye or systemic pathologies. The study periods included the pre-lockdown period, lockdown period, and post-lockdown till 31st July 2020. The results were in the table, as we can see, the OPD and IPD trends in the eye department in 2020. The observation, as we can see that in May, we recorded the lowest IPD occupancy at 0.3%, as compared to, for example, in January, which was 87.03%. And then the overall reduction, both OPD visits and admitted patients across the month of May. And then again, there was a rise in July post-COVID, around 12 to 25% when it was increasing. It started to increase again. Here we can see the monthly distribution of ophthalmic references. We can see in May had the lowest percentage of booked preterms, that is 0.99% of deliveries, and only 6.38% of preterm births were booked, indicating a decrease in the preterm follow-ups. And again, we can see, for example, in January, it was 5.79%, and then it decreased to 0.99% in May. And again, the trend started to rise in July, like 3.93%. In the ophthalmic screening in lockdown period, in the year 2019 versus 2020, we observed that there was a significant decrease in booked preterms during the lockdown, and the preterm births reduced significantly, suggesting conversion of the term births among those with regular antenatal care. And the last table, we observe that there was no, in the average gestation of preterms in 2020, there was no significant difference in gestational age across the three phases, that is pre, during, and post-lockdown. Discussion, the impact of COVID-19 lockdown, there was a decline in ophthalmic services and preterm births which were observed. In global preterm risks, we see that prematurity causes visual impairments with stress, sleep deprivation, and periodontal diseases as a key factor. Ethnicity affects birth rates but not the outcomes. Ophthalmic issues in preterms, high risk of ROP, as we all know, strabismus and visual deficits require long-term monitoring. And COVID-19 and eye health, the COVID-19 linked to conjunctival symptoms, but no vertical transmission found. Breastfeeding was allowed with masks. Limitations and conclusions. The limitations, we see that the findings reflect the perspective of ophthalmologists only. More facets need exploration to form a comprehensive hypothesis. Limited follow-up data on long-term outcomes of preterm births during lockdown. The conclusion of the lockdown led to a decline in the ophthalmic references, including preterm screening. There was a decline indicating a positive shift towards the deliveries. The study provides a unique perspective on external stimuli influencing antenatal outcomes. Further research is required to determine if this trend was nationwide. The key message and future directions: primordial prevention of ocular anomalies is essential. Environmental changes can result in favorable pregnancy outcomes. Future research, broader studies on external factors and preterms can be studied. These are my references, and thank you.
We are very blessed. We have our AIOS president, former AIOS president, Dr. KPS Malik sir with us. It's a very big honor for us that he is.
So next we have Dr. Prakhar Saxena.
We didn't get the question. Can you come back? So just one question. Do you have any statistics now of all the kids who were missed at that time, who were not screened properly? And while you have taken a lot of things into consideration, we are mainly concerned with ROP, with preterm.
Yeah.
So do you have any data right now that these kids were born at that time preterm and were not screened, and because of which they are blind now?
That data right now, sir.
Next speaker is Dr. Prakhar Saxena. So he will be discussing about the study to compare the result in early versus late traumatic. Dr. Purva.
Good morning, everyone. I will be presenting the presentation to evaluate the spectrum of dry eye disease and its effect on central corneal thickness in postmenopausal females. Dry eye disease is a prevalent ocular condition characterized by a disruption in the tear film, leading to symptoms such as ocular discomfort, visual disturbances, etc. It affects individuals across various demographics, with postmenopausal females being particularly susceptible due to hormonal changes associated with menopause. Postmenopausal women with comorbidities are at a greater risk for developing dry eye syndrome and the subsequent negative effects on their eye health. While the clinical manifestations of dry eye disease are well documented, its impact on corneal morphology, specifically central corneal thickness, remains an area of interest and debate. CCT is an essential parameter in assessing corneal health and is influenced by various factors, including hydration status, inflammation, and mechanical stress. Understanding the relationship between dry eye disease and CCT in postmenopausal females could provide valuable insights into the pathophysiology of the disease and guide clinical management strategies. The aims and objectives were as follows: to evaluate the spectrum of dry eye disease in postmenopausal female population, to analyze the severity of dry eye disease with the duration of menopause, and to study the effect of dry eye and its correlation with corneal thickness in postmenopausal females. It was a prospective observational randomized study that was conducted to evaluate the spectrum of dry eye disease. It was a sample size of 90 cases were taken. Patients in the study have been divided into 3 groups. Group A, females were aged 45 to 50 years. In Group B, greater than 50 to 55 years. And in Group C, females were aged greater than 55 years. The following data was collected: name, age, visual acuity without correction, with correction, Schirmer's test, tear film breakup time, ocular surface disease index score, central corneal thickness, and the level of hormones, especially FSH, LH, and estrogen, were recorded at day 1. The Schirmer's test had been performed. The following tests were done. The results were as follows: a value of Schirmer's score in both the eyes in all 3 age groups. In the right eye, 45 to 50 year age groups show a mean of 8.1 Schirmer's value. In Group B, that is greater than 50 to 55 year age groups, show a mean of 6.96 Schirmer's value, and the Group C shows a mean of 6.71 Schirmer's value. Schirmer's value show a significant decline with age, increase in age. In the left eye, the Group A showed a mean of 8.6. Basically, Schirmer's value show a significant decline with increase in age. The tear film breakup time in both the eyes was taken, and according to the study, but values also show significant decline with increase in age in both the eyes. the ocular surface disease index score in group A, age groups show a mean of 29.97 OSDI score. Group C, basic OSDI values also show a significant increase with increase in age. The central corneal thickness. In the right eye, group C, basically CCT shows value show a significant decline with increase in age. In left eye also, it shows a significant decline with increase in age. The mean CCT value of both eyes, right and left eye, show statistically significant results. Thus, it can be stated that CCT declines with age. Now we compare the hormonal results. In the hormonal tests, FSH, LH with age and estrogen show decline with age. All results are statistically significant. Further statistical analysis was done to find any significant correlation between the effect of these hormones on the CCT. The effect of hormones on central corneal thickness is non-significant. The patients were taken on OPD basis and findings on day 1 were noted and observations were recorded. Schirmer scores were found to be decreased in patients as their age increased. T-Butt score was also decreased with age, but they were not significant. In case of OSDI, it showed an increase in its value, indicating increasing severity of dry eye with age. The above findings state that the spectrum of dry eye disease in postmenopausal female population worsens with age, and also the severity of dry eye disease increases with the duration of menopause. In our study, CCT tends to decrease with increasing age, although the extent of this decrease and its clinical implications can vary among individuals. The correlation between increasing age and a decrease in central corneal thickness has been positive in both the eyes. There was no significant correlation seen between CCT and reduction in hormones with increasing age after menopause. In conclusion, the study highlights the significant impact of menopause on dry eye syndrome and provides initial insights into the potential correlation with central corneal thickness. The findings underscore the importance of personalized approaches managing ocular health in menopause. Continued research and efforts are essential to deepen our understanding of these relationships and improve outcomes. Thank you.
You were in particular trying to see the central corneal thickness in patients who had dry eye disease?
Basically, sir, in postmenopausal females, the study group that was taken were females who have had a significant
so was it compared to like men having dry eye disease in an elderly group?
No, sir, it was compared between increasing age.
Corneal thickness?
With increasing age only in postmenopausal females. The study group was females. Males not.
My question is, why did you select this topic first? Second is, how can you measure the CCT of, you have taken groups of people, in spite you have a same patient, a study has to go on for 5 years or 10 years. Then you can comment on this exactly how the cornea is changing. You are taking different individuals of different ages, you cannot compare that way. Got it? Like
yes,
if your cornea has been measured at the age of 45, at the age of 50, at the age of 55, then it makes sense that it has some difference. Or then we can comment like with aging the cornea also decreases in thickness. Apart from that, you can't compare her eye, everybody's eyes. Okay.
Ma'am, age groups, yes,
yeah, but practically speaking, if in person, you have to see in an individual person.
Yes, ma'am.
Then you can make groups of that age group.
Nahi, sir. Dr. Sanjeev, sir. Sanjeev, sir.
Thank you very much. Thank you.
So next in line we have Dr. Prakhar Saxena. So he will be discussing about to study the compare the result in early versus late traumatic cataract surgery and intraocular lens implantation.
Good morning everyone. I will be discussing study to compare the result in early versus late traumatic cataract surgery and IOL implantation. Introduction. Loss of vision due to ocular trauma is an important public health problem around the world. More than 500,000 people around the world are blind due to ocular injuries. Ocular trauma may lead to traumatic cataracts and thus contribute to notable visual morbidity. Traumatic cataract surgery can be performed either early in association with repair laceration in open globe injury, at early days after presentation of penetrating injury, or as a late procedure in a quiet eye. If the lens capsule is ruptured and lens material has been introduced into the anterior chamber, it is preferable that the lensectomy can be performed as early procedure to prevent inflammation, lens particle introduced uveitis and glaucoma. Another advantage of performing the early surgery can be performed during same admission and reducing cost and time. The advantage of late procedure includes better IOL after suture removal. The literature available shows no consensus in timing of cataract surgery and its prognosis. Hence, it was decided to take up this study with the aim of comparing the advantages and disadvantages of early and late traumatic cataract surgery. Study was conducted in Department of Ophthalm, Muzaffarnagar Medical College. It is a prospective interventional study, and all patients with traumatic cataract who fulfilled the criteria were taken in the study. Patients were divided in two groups. First group, early cataract surgery in same sitting, and second group, late cataract surgery in the repeat sitting. The image shows the cataract surgery and repair of the lustration of the patients included in the first group, and the second picture shows the repair done in the first sitting, and cataract will be removed in the second sitting. Following surgery, topical antibiotics, corticosteroids and cycloplegics were prescribed, and further some examinations were conducted. The data was compiled using Microsoft Excel sheet using some standard tests. The results were that the age group less than 20 years who underwent early cataract surgery were 53.3% patients, and 60% underwent late cataract surgery. Further, the more affected gender was males. 66.7% underwent early cataract surgery and 60% underwent late cataract surgery. The type of soft trauma, blunt trauma was in early cataract surgery 63.3% and 70% late cataract surgery. Mean axial length was 25.7 in early cataract surgery and 21.1 in late cataract surgery group. In early cataract surgery group, about 36.7% of patients in this study had vision between 618 to 624, and in late cataract surgery, about 46.7% of the patients had vision between 618 to 624. And during post-op, in both the cases, the vision was improved to 6.6 or 6.12. About 63.3% of the patients of early cataract surgery and 40% of the late cataract surgery had bag type of IOL. Inflammation was present in 10% of patients in early cataract surgery group, followed by raised IOP in 10%. In late cataract surgery group, raised IOP was present in 6.7% of the cases, followed by other complications. This study shows that about 30% of the patients with early cataract and 33.3% with late cataract were aged between 21 to 30 years, which was statistically significant. Another study also proves the same results. Other studies have also revealed that ocular trauma mainly involves children and young men. Hence, it is reasonable to perform the early cataract surgery to make visual rehab shorter and help in better anatomical and visual outcomes. On the other hand, late cataract surgery could permit to better IOL calculation, probably operating in an eye with less corneal edema, inflammation, and better evaluation of traumatic cataract. One study has also proved was done to determine the effect of interval between time of injury and time of intervention. In these patients with corneal restoration, traumatic cataract surgery was performed as a secondary procedure, and these group of patients had a significant higher post-op inflammation and lower final BCVA. They concluded it was better to perform traumatic cataract surgery as an early procedure because of lower complication rate. Other studies also proved that in the absence of fragmentized or intumescent traumatic cataract, to manage traumatic cataract, it is preferable to do secondary procedure. One study mentions that for better assessment of visual improvement after surgery, more accurate IOL complication and less post-op, it is preferable to do secondary procedure. Also, Agarwal et al. Have suggested that in the presence of severe corneal damage and edema, it is better to postpone lensectomy for better visualization during surgery. In the present study, we tried to make a model to find the proper time of cataract surgery. We did not, and we found that at 6 months post-op, the BCVA showed no difference among the patients in the two groups. PCR was not statistically different between the two groups. We found more zonulisis in the group 2. Finally, according to the study, there was no difference regarding visual outcomes between the two groups, and no difference regarding intra or post-op complications. So early and late interventions could be considered equally according to the situation of each case and the treatment environment. However, we need more trials addressing mentioned limitations to say the correct timing of traumatic cataract surgery. Yes sir, sir जो young age में उसमें सर blunt trauma सर वो थोड़ा
यही सबसे प्राइमरी क्वेश्चन है good 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 it is definitely at that age you could not make it is wrong when beyond 20 you would expect that Allah can certainly know but Allah can certainly even adults also if you keep a cataract unoperated for years and years even adults could lose the vision of that eye though it may recover but you have to occlude the other eye then only it will recover once binocularity has developed of course the chances of recovery are more definitely good very good thank you very much please दीजिए कि प्रणाम उसका yes
So next we have Dr. Parijat, and his topic is corneal surface changes in eyes undergoing pterygium excision surgery. Sir, one question from Dr. Malik sir regarding the IL power calculation.
yes
In cases of trauma. So are we taking the K value of the other eyes?
I for axial length of the eyes and anything else yes
Okay.
neither your cornea is what to the left neither your IOP nothing really matters the length of the eyeball would make a definite some idea that this is and then no whatever sir is asking can we take the K value of the other eyes oh yes definitely 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 that is the K value for the eye definitely would help but you know the trauma and astigmatism is so much in the traumatic this patient where cornea is first way
Good morning, esteemed judges and faculty. I am presenting the study which was corneal surface changes in eyes undergoing pterygium excision surgery. So basically, progression of pterygium alters the curvature of cornea, which often leads to the development of corneal astigmatism. In advanced cases, it can lead to significant diminution of vision and discomfort. And in India, the prevalence ranged from 9.5 to 13%. So the aim of this study was to see the corneal surface and topography in patients with pterygium and to draw the comparison before and after pterygium excision surgery. And it was done by assessing the astigmatism and the keratometries in eye with pterygium and to evaluate the corneal topography after pterygium excision surgery. All the patients above 18 years were considered, and any patient which had history of any previous ocular surgery or trauma or any infection, any intraocular inflammation, or any patient which had pterygium but was posted for any other type of surgery was excluded from the study. It was a prospective observational cross-sectional study, and 100 eyes with pterygium were considered for this study. Visual acuity and near vision was done by Snell's chart and Jaggers chart respectively. Keratometry was assessed by the automated refractometer, intraocular pressure by non-contact tonometry, and dryness was assessed only on the basis of tear breakup time. So the age gender distribution mainly in our study denoted that it ranged, the maximum number of patients were from 31 to 60 years of age, and there was male predisposition of pterygium in our region. And the major cases which were operated were of type 2 pterygium, and then it was followed by type 3 pterygium. Then on keratometry, we saw that pre-operatively the vertical keratometry mean was higher than the horizontal keratometry mean, and it was significantly higher. And then post-operatively, we saw that there was significant decrease in the difference of vertical and horizontal keratometry mean. And with time, the difference reduced, and the amount of astigmatism also reduced post-operatively on 3rd week. And for tear breakup time, we assessed that pre-operatively and post-operatively, there was 10% increase in the patients which had tear breakup time less than 8 seconds, and it was significant. So in our study, the prevalence was more towards the middle age to the elderly age, which suggested age-related susceptibility or exposure to the environmental risk due to work or lifestyle. Also, many studies have showed that the prevalence of pterygium increases in linear fashion with age. Like Vinay Nanja et al. Stated that the prevalence of pterygium, which increased from 6.7 plus minus 0.8% at the age of 30 to 39 years to 25.3 plus minus 2.1% at the age of 70 to 79 years. And there was male predisposition in our study, and various other studies have stated the same, that the male disposition, the amount of males were more affected than females in for the pterygium. There was only one study which was on the Chinese, which in rural area, which showed that there was increase in female predisposition. Else all other studies stated that males were more involved than females in pterygium. Astigmatism has been the highlight in pterygium. Pterygium may cause the flattening of cornea to the leading apex. As Maheshwari et al. Stated, an induced astigmatism was explained by several mechanisms, like pooling of tear film at the leading edge of pterygium and the mechanical traction exerted by the pterygium on cornea. And in their study, the corneal astigmatism which decreased from 3.47 diopters to 1.29 diopters, and the mean difference in corneal astigmatism change was 2.18 plus minus 2.34 diopters, which was significant. Wu et al. Found a significant correlation between the differences in refractive cylindrical power before and after surgery. In our study, pre-operative astigmatism, which was significant, was found in 90% of patients, and post-operatively only 10% had significant astigmatism. So the conclusion of this study was that the limitation of our study, that it was a very small size, and there was diverse range of age which could undermine some findings in the ocular surface. However, this diversity in age group should also highlight some common ocular features that is attributed to all ages, like astigmatism, dryness, which reflect the association with pterygium. More studies related to the individual factors are need to be done in our region for better understanding of pterygium and its association.
The astigmatism has improved in almost 90%, it has come down to 10%. So first thing is what size pterygium you have taken. Grade 2 you told?
Major cases were grade 2 pterygium.
So what do you mean by grade 2?
Grade 2, when it has encroached over the cornea, it is between the limbus and the pupillary margin.
So when it is between limbus and pupillary margin, so how many? It's and what about grade 3?
Ma'am, when the pterygium is at the pupillary margin, then we call it as grade 3 pterygium.
Pupillary margin, okay.
I'll definitely go through. जी सर, जी सर.
My method, you know that suture less and all that. Another general knowledge I was giving is that in Thailand, we visited the primary health centers and all that. Their pterygiums are bitemporal, by nature, and hundreds, and they operate like chicken and put in the throat behind the nurses throw it, the handle throw it, cut it and throw it, nothing else. I don't know today. This was the scene in 90s, and I don't know why they had so much pterygium. वो इतना लिटरेचर उन्होंने लिखा नहीं है, पर इतना pterygium मैंने दुनिया में कहीं ना सुना ना देखा. Your paper was basically on corneal surface changes. Your entire presentation, only 2 slides were touching that particular subject. So in future, when you're making a presentation, it would be a good idea to just focus on the corneal surface changes after the pterygium excision, like showing photographic pictures and all those things?
So actually our setting doesn't have a pentacam, so we couldn't manage to do that.
So we have something to learn from each other. So the next we have Dr. Bhadoria, and she will be discussing about the profiling of contraindication for eye donation in a hospital corneal retrieval program in a tertiary care hospital of Uttarakhand.
Good morning everyone. Today I'll be presenting my paper on profiling of contraindication of eye donation in HCRP in a tertiary care hospital of Uttarakhand. So basically the aims of my paper was to identify the factors which act as a contraindication during eye donation in the hospital corneal retrieval program in tertiary care hospital of Dehradun and Uttarakhand. So this study was organized in Sri Mand Indresh Hospital, which was a prospective non-randomized cross-sectional study done for 18 months, and the sample size was 500. Basically, we included those patients who had any contraindication of eye donation at the time of death, as stated by Eye Bank Association of India, and the attendants were willing for eye donation, but we couldn't retrieve the cornea. So this is a table enumerating various contraindication of eye donation as per EBI guidelines. The exclusion criteria in our study was those who were willing for eye donation and had no contraindication at the time of presentation, and donors who refused eye donation at the time of examination. So basically residents were posted in various intensive care units and attended mortality calls coming from various ICU, and they evaluated the medical records and corneal status of potential donor, and if there was any contraindication, the eye donation call was avoided. So as per our results and observations, we found out that in 500 patients, the number of males were more than the number of females. As according to the distribution of age group, the age group of 61 to 80 years had the major chunk of patients as compared to 41 to 60 years of patients. As per distribution of number of cases, so the maximum cases we observed were of sepsis, followed by viral markers, and followed by viremia, but other cases are very less in number. We divided the cases of sepsis into on the basis of blood culture. One was blood culture positive, second was blood culture negative, and third was in blood culture was not sent. So we, in sepsis, so blood culture was, the maximum cases were in negative blood culture. As per viral markers, so HCV was the maximum, the cases of HCV were maximum. So in our study, the sepsis was the leading cause of rejection in 500 potential donors. As per these studies by Maya AL et al. And Venugopal KC et al. So they also demonstrated that the maximum rejection was due to sepsis. So why sepsis drafts are rejected? It is basically, there is a possibility of endophthalmitis in patients, but they have to be rejected due to guidelines. But some studies that have been done elsewhere have shown that when the corneas were transplanted from 91 septic donors, so there was no case of endophthalmitis in the recipient in the subsequent follow-ups. And in an HCRP setup, so they also evaluated the cause of rejection of tissues in the study, but they had to reject 46 corneas due to sepsis, out of which 23 were good quality tissues. And for the third study, he concluded that the only sign which conferred to active septicemia was positive blood culture. Other signs did not correlated with the active septicemia. Among viral markers, HCV was prevalent in our study. So Sharma RL et al. In the study, they also had HCV seropositivity positivity more than HbA1c or HIV. It is because due to the fact that seropositive cases that were taken from ICUs had been diagnosed with CKD or CLD. So these cases had HCV at the time of presentation. So these cases are predisposed to HCV. So if I conclude, the strength of my study it was a purely observational study which primarily focused on the profiling of contraindication. So screening guidelines have been strictly followed by all eye banks all over the country, which ensure healthy tissues to be circulated among hospitals. So as we talk to the patients and staff, so there is a chance of increased awareness about eye donation. So limitation for my study was not many studies were available exclusively to this topic. So guidelines for sepsis has not been updated by the organization, which is leading to loss of good quality tissues. So basically there was no case or control group in my studies. So the comparison would have made my study stronger, and limited evidence and research for causes of rejection in patients diagnosed with TB. Thank you.
So in part you're trying to say that sepsis cornea should not be taken, and then you said some studies have shown that it can be taken. What did your study conclude?
So basically, my study concluded that sepsis has been the leading major cause of rejection of tissues. But since we follow the guidelines only as per EBI, so there has been a loss of good quality tissues during these due to rejection and due to following these guidelines. Sir, if there is blood culture negative, so we can take it, and if blood culture is positive, so we should definitely not take it. Ma'am, 3 days. Within 3 days. Well,
Now we have the last speaker, Dr. Pratik Nishant, and I think he's from the first batch of AIMS Rishikesh, where there is MS from AIMS.
Thank you, sir. Good morning, esteemed panel. Correlation of MIBO scales, symptom score and sign score for MGD in Indian eyes. I have no financial interests. MGD is characterized by terminal duct obstruction and changes in glandular secretion. It is the most common association of dry eye disease, and there are known risk factors for MGD. There are many grading scales which are available for MGD, but they are very cumbersome. In addition, there is significant inter-observer variability. The OSDI, the symptoms is the symptom score, the 6 MGD sign scores, and the improved MIBO scales are means for assessment of the meibomian gland disease. But non-availability of validated MGD grading scales suited for the Indian outpatient setting is a gap in the present knowledge. Although the 3 systems can help in grading of MGD, extensive literature review did not reveal whether a correlation exists between them. So the evaluation of the correlation will analyze whether the improved MIBO scale used alone can determine the severity of MGD, or a combination of grading systems is actually needed. To the best of our knowledge, there is no study to correlate the meibomian gland loss as per the improved MIBO scale with existing symptom and sign scores in the Indian settings. So this was the hospital-based cross-sectional study from October 19 to May 20. It was approved by ethics committee, and primary MGD subjects were included. All participants filled the OSDI form, underwent complete ocular examination and eyelid margin examination, and the MGD sign score was calculated using the sum of 6 grading systems. Infrared imaging of the upper and lower eyelids was done using a specular microscope, and the areas of meibomian gland loss were visually assessed, and the score was assigned based on the improved MIBO scale photographic card. So the OSDI was calculated as per standard formula. The 6 grades were assigned as per the grading which is as shown and which is standard, and the MGL score was assigned by comparison of the MGL areas with the figure on your right, which is the improved MIBO scale. On the left, you can see the specular microscopic findings, which clearly demonstrates all the areas of meibomian gland loss. And in the center, you have the slit lamp examination of the upper lids and the lower lids of the patients of meibomian gland disease. So based on the findings from a pilot study, the sample size of 124 eyes was calculated, and appropriate statistical tests were used, and scatter diagrams were used to visualize the findings. Spearman's correlation coefficient was used to determine the correlation, and a coefficient of greater than 0.5 was considered clinically significant. The JT test was applied to evaluate the distribution of varying ordinal scores, and the R effect of the JT test was used to calculate the effect size. So 68 subjects were included and 212 eyelids were included. The OSDI ranged from 6 to 90 and the science scores from 0 to 15. The MEBO scale scores ranged from 0 to 4. There were 29 males and 24 females. The distribution of OSDI as per the science score and the MGL score, which is the MEBO scale score, is as shown. These were not clinically significant, but the comparison of MGL score with MGD science score showed strong correlation, which was statistically significant, with a correlation coefficient of 0.83, which is again clinically significant as well. So the JT test applied for the correlation between the meibomian gland disease sign score and the meibomian gland loss that is evaluated on the MEBO scale, showed a very statistically significant JT statistic, and a very large effect size that is evaluated from the JT test. So this study evaluated the validated symptom score, the sign score, and the improved MEBO scale. And there are very few comparable studies which are conducted in the past which have evaluated the clinical utility of photographically aided scales, such as this scale, in comparison with existing symptom scores or sign scores. Excuse me. Arita et al. Have assigned scores to the 6 parameters, the sum of which forms the existing basis of diagnosis and the assessment of severity of meibomian and gland disease, and it requires both slit lamp biomicroscopy and meibography. And in that article, they have provided the representative images for the grading of MJD. Though useful, it is time-consuming and cumbersome in the clinical setting. The visual scale, known as MEBO scale, comprises of a picture card and allows the observer to assign a score depending upon the image to which his condition corresponds. Linear regression analysis is well correlated with the OSDI score, which is calculated by Pult et al. However, this is not possible in the clinical setting. Wang et al. Have used the sum of scores of both eyelids, but correlated this with the speed questionnaire. Computer software can be used to analyze the areas of meibomian gland loss, which is available in commercial meibomian gland analyzers, but again, this is very cumbersome and costly. Robin et al. Have evaluated that the OSDI and the mean NGL score are well correlated in subjects that are, that are presenting with meibomian gland disease, but they did not correlate the 2 parameters among these patients. And Brooks and Gupta have shown that the MEBO scale score in refractive surgery patients. So now, MEBO scale alone can be used for reliable assessment and grading, but we still recommend independent symptom assessment. Thank you. Original work from AIIMS Rishikesh in UK SOS. There you have it. Thank you, sir.
Thank you. We'll make we can do the totaling outside.
So with this, we thank all the judges for chairing this session.
A group photo. Can all the presenters please come in?
नीचे बैठ